Welcome everyone to the RSN Internship and Community Service Talk. As you know, we are coming to the end of the Rural Health Awareness, and we hope that so far you have Awareness Month, sorry, and we hope that so far you have enjoyed all the events we've had planned for you. Today is a very special one for us because we are joined by health professionals that are working in the very healthcare that we are advocating for. Today we are joined by Megan Aransa, who is an occupational therapist, Dineo Baloy, who is an audiologist, and Siwe Masiza, who is a physiotherapist. They will be sharing their experiences working in rural health with us. We are expecting one more guest, Wanye, but he'll join us as the talk goes on. So to start us off, would each of our guest speakers, like to introduce themselves and just share where it is exactly that you are working and how long you have been working there? We can start off with Dineo Baloy. Could you please?
Hello. Can you guys see me? My name is Dineo Baloyi. I did my audiology ComServe at Zithulele Hospital, which is in the deep rural Transkei side of the Eastern Cape.
Thank you. And how long did you work there? Just for the ComServe, or did you work?
Yeah, ComServe and post-ComServe, I moved a little bit to the KZN side, still rural. So I'm at Madzikaneka Zulu Memorial Hospital.
Thank you so much. And Siwe Masiza.
Hi guys, my name is Siwe Masiza. I'm a physiotherapist. I did my ComServe last year at All Saints Hospital, which is in Ngobo, also rural. And then I'm doing my post-ComServe now it's also in the same district. It's in Lady Frey called Glen Grey Hospital.
Okay, thank you. And Megan Aransa. Megan, I think I saw her as part of the system, so she should be here. And I think the last one we're waiting for is Wanye, who is also an occupational therapist.
We can call on Megan again. She just joined now.
Okay. Megan, we are in the process of asking our guest speakers to introduce themselves and share where it is that they are working and how long they've been working there.
So I'm sorry, I'm late. I'm actually trying to find signal. The power, can you hear me?
Yes.
The power's off here. It just went off at 5 and the signal gets really, really bad here. So I'm outside looking for signal. I'm gonna try and go inside now. I'll be back with you in like 2 minutes.
Okay. I think as we wait for her and Wanye, I think who we're still waiting for, he can go into the talking points for today. So today we decided to have a bit more of a discussion where we can compare each of your experiences as opposed to having one of you speaking for about 10 minutes. So, yeah.
Thank you for those introductions. So we'll hear from Megan and Wanye in a bit. To get us started, we're starting with the first question. I believe the speakers got the questions beforehand. So the first one is, what is the biggest adjustment you've had to face between working and studying in Cape Town to now working in the rural area? So any speaker can just start us off, whoever is willing to speak first.
Okay, so I'm not from Cape Town. I'm from Pretoria, but it's still like a city. So I feel like the biggest challenge that I had was the cultural differences or the cultural shock that I had to adjust or I had to come to terms with here in the rural area. For example, it's like greeting. Like here, they take greetings very seriously. So before you even utter anything, if you did not greet the person, you will not be assisted. They will not take you seriously. And how you address the people appropriately, because now here it's royals most of the time. So you can be like in your consultation room, a chief comes for a consultation. So there's terms that you must like use, especially and mostly they host in dabas because it's a rural area, not everyone has access to the internet. So if they're hosting an indaba, you must know where to sit, who to approach. You're not supposed to say this, you're not supposed to approach that. There's like a protocol for each and everything. So I think for me it was just the cultural like shock and the cultural differences because I'm from the city, and like greeting someone and not greeting someone, it's not much of a big deal as opposed to hear what it means and what it actually stands for and where it actually stems from also. So yeah, it's that for me.
Thank you so much, Dineo.
Yeah.
Is there another one person who wants to speak?
Okay. Can you hear me?
Yes, we can.
Yes.
Okay. So for me, the biggest adjustment was resources. Oh, yeah. So we in Cape Town, and when I was studying, we had a lot of resources to work with. When you get this side, yeah, resources, the struggles with resources, and also having to adjust to speaking one language. In Cape Town, I used to speak lots of languages, so now I only have access to one language. It is just a me thing, but I like that variety of languages. And then also, I'm from Upper Northeastern Cape, and I'm in Mid-Eastern Cape now. So it's also the cultural things that I'm still adjusting to. But it's been quite fun though. Maybe it's because I'm always open to new interests and things. But yeah, yeah, I mean.
Thank you so much, Siwe. So for everyone who's just joined, we are tackling the first question. You can find it in the chats. I'm not sure if you can find it, like if it was posted before you joined. But the question is, what is the biggest adjustment you've had to face between working and studying in Cape Town to now working in a rural area? So we can have our next.
Is that me? Yeah. Hi. Okay, so I'm Megan. I'm inside now, but if my signal cuts out, I'm really sorry. Wanye, the other person who was meant to join, can't join because he's living in a village. So the power's also gone there, and when it's gone, it's gone. But I'll try my best. So what did you start off with? Anything that I missed?
No, it was just the introduction about like, okay, your name and where you come from, like where you work and maybe where you studied as well.
Okay, so I studied at UCT. I've lived in Cape Town my whole life, and now I'm working in Lusiki City at St. Elizabeth's Hospital. It's the only regional hospital by far. We've got a bunch of other surrounding districts, but we are probably the biggest one by far. So to answer the first question, coming here, I knew what I was coming into because this was actually my first choice. So I knew a lot about the place. And I think doing research helped because it wasn't a huge transition for me. I've also worked in rural Eastern Cape before. I came here in 2018 for a bit, so I wasn't completely shocked by the differences. But I have to agree with Steve. Is it Steve? Sorry, I'm not sure who was speaking earlier.
Steve.
Okay. It has to be resources, because all of my blocks in university, we had a whole bunch of things we could access, and then coming here to almost nothing. You really have to learn to make tools and just work with what you have. And also just access to basic things like shops. If I'm going to like Durban or Cape Town for leave, I make sure to stock up on a lot of things because there's stuff that you can't get here.
Okay, thank you so much. Did you want to say something to me?
Me?
Yes.
Oh, no, I don't want to say anything.
Okay.
Also,
so sorry.
Also, network is a major thing.
Yeah.
It's terrible. Like today is a lucky day that my network is fine.
Now
So if you
used to
max network,
I can imagine, especially being used to Cape Town's network, good network. Okay, so I think we can move on to the second question, which is, what is the workload like in the sense of what is the patient to practitioner ratio, and how many patients do you have to see roughly in a day?
I'm sorry, should I start? Because it's like, okay. Well, last year I had a supervisor. So, and this year I'm starting the department from scratch, you know? So I'll just share both of my experiences. So with a supervisor, it was much easier for me to actually adjust to the workload and to adjust as to what I'm supposed to do. Ne? But during the course of the year, he had to attend to some personal stuff. So I was the one who was left with the department by myself. So I had to actually do everything by myself. So we had neonatal hearing screening, we had outreaches, we had high-risk clinics, we had school visits and home visits. We did OPD and wards. So the workload was a little bit too much for me because we saw almost 5 to 6 clinics twice a week. And in between also hosting indabas. And our working hours were from 8 until 5 every day for Monday to Thursday, and Friday it was from 8 until 12. Name. So the workload actually where I was it was mostly determined on which day of the month it is. So if mostly in the rural areas, they depend on the social grants, any type of grant, social grant or pension grant. So the workload would be more like immense during the first week of the month or the middle of the month after they've had like IPE, yeah, they call it IPE. So in a day, I would see, let's say 7.
Sorry, Dino, I think you're breaking a bit.
I'm breaking a bit. Can you hear me now? Sorry. Can you even hear me? So in a day, I would see.
We can't hear you.
Can't at all.
Can you hear? Mohadi is the problem on your side because I can hear her clearly. Like she hasn't. Yeah, I can hear.
Yeah. So I was saying. So the workload depends on a lot of factors. I said social grant. I also said the weather. So most of the people here, they don't have any form of like readily accessible transportation. So during rainy days, during stormy days, I would see less patients. So I would know if the weather is like this, I'm expecting less than 5 patients. If the weather is like that, I'm expecting this amount of patients. So it wouldn't even be about how many patients that I book on that day. And yeah, and now because I'm starting a new department here, which is a little bit tricky, in the first month I didn't see any patient, so I had to start from scratch. I had to start with promotion, right? So you know how promotion is. I went to every ward, introduced myself, who I am and what I do. And in the second month, I think I started seeing a little bit of patients, like I would see 5 patients a day, and that has slowly picked up. So my workload is more because now I'm not just a ComServe, but I'm also a supervisor. So I do admin stuff on top of me seeing patients. I do admin, I procure stuff, I advocate for equipment. So yeah, so the workload is more, my responsibilities are more, they have changed. And yeah, I mostly just depend on myself. So yeah, for me that's about it. The workload is not a lot. It just determines, it just has factors that determines how things are gonna be. So yeah, that's what I can just say about my experience so far.
Just a question. When you say you have just started your own department, are you the only one who works there now, like in that department?
Yes, like in the last 10 years, there hasn't been any audiologist. So when they placed me there was literally like no equipment, like there was nothing. So I had to actually advocate for some stuff to be bought. I actually had to ask finance to give me funds. So I had to go to the, like, literally call district and say, hey, this is what's happening. I'm new, you placed me here, I'm not doing anything. Can you please fund me? And then they did fund me. But now it's procurement. It's ordering stuff, which is kind of the hectic part because I don't know anyone who's like above me. I only know myself. And last year I was kind of like too laid back and being, you know, the girl at the back who just sees patients. Now I'm literally at the forefront of everything. But yeah, that's it.
Thank you so much for that. So did you want to answer?
Yeah. Does anyone have questions for Okaru now?
Yeah.
No, I'm asking you, does anyone have questions for you before I start? Okay, I'll just start. Okay, for me, what was the question again?
Oh, the question was basically about the workload and like the
workload.
patient to practitioner ratio. Yeah.
Oh, okay. For me, I started before the lockdown. So before lockdown, so that was January, February, and March last year. That was when we had the most of our workload, and we knew between the first, because those were the times of grants, between the 1st and the 10th, OPD was full, right? So OPD would be full and you would see like close to 10 to 15 patients a day. But luckily there was 2 of us. There was me and another physiotherapist. But we had one disadvantage because in our department, we had 1 bed and there was 2 physiotherapists and 1 OT. So we had to maneuver around that. So we had to be creative with how we saw patients. So yeah, for that, resources. And then And then we knew around end of the month, we would have more ward patients on surgical side. And then on the medical side, we usually had, I don't know why, between the 18th and the 28th, we had a lot of patients in the ward. I don't know why, but it was mainly strokes and diabetes. And then there's something they call generalized body weakness. I don't know what it is. I've been trying to look it up. I still don't know what it is, but it's just called generalized body weakness. And then, okay, last year I had a senior who did all those things, those fancy stuff that Dineo does. And then this year I also have someone who's been working longer than me. We just share some of the stuff. I only do procurement. Then she does everything, the stats, handing in of stuff, speaking with Unolu and all that. And this side, in terms of the workload, we've been struggling with the wards, but on OPD side, we quite have a good workload. But it's not that hectic. On the ward side, we just have a problem with the referrals from so we're still advocating for physiotherapy, and I also work with another OT, so we're still doing all that. Yeah, and we have a problem with procurement. So you need to be patient and also be assertive this side when you're working with procurement, because you need to be patient because the stuff takes a while to happen, and then also you need to be assertive because people get lazy. Yeah? So that's another difference between Cape Town and this side. This side you have to keep following up on people. In Cape Town, people knew that you're supposed to do this. This side you have to just be on people's backs. I'm done.
May I ask, seriously?
Yeah.
You mentioned that you have to keep working with procurement, and following up. Can you please just let us know what that entails, what it is exactly that you have to work on them with,
Okay.
for those who may not know?
So in the hospital, there's something called a bus report. Né? So in the bus report, it tells you how much your budget is for each, but then in the bus report, they don't tell you this is the physiotherapy budget. Né? It's only OTs that have an OT budget. We get a wheelchair budget and we get a crutches budget, right? So in terms of procurement, from our side, we have to find contracts for the one that I'm focusing on now. It's crutches. You have to find the contract. And then after that, you have to speak with the people with the contract if they have the stock or not. And then if they do, then you bring the contract to the procurement, and then they have to start the procuring process. Then after they do the procuring with the company, then if the company approves, then the things are sent to district. Then at district level, it's brought back, and then there's a cost containment meeting inside the hospital in which that you have to be there so that you approve what you did. Then there's everyone comes to that meeting. It's every Tuesday on my side. So every Tuesday we have to go on the cost containment meeting, and then we have to talk. It takes like 4 to 5 hours sometimes. And then you're sitting there and then you talk. Basically on a cost containment meeting, they're trying to limit the costs. And that is around the time you find out if they're gonna shift your funds or not. Usually when they want to shift funds to somewhere, they start with rehab, right? So like this year, before the financial year started, we had a 44,000 budget for crutches and they took 20. So now we're left with 24,000 Rand for crutches, and we have to use up all that money. before July. Then because in July, they're gonna start shifting the money again to other places. So you always have to keep following up on them. Yeah, it's just a whole thing. I'm learning all this stuff as we go. Yeah. And it's important for you to know who's your supervisor. Because this side, my supervisor is the clinical manager. So but in other hospitals, your supervisor as a physiotherapist can be the CEO, right? So you always need to know who's your supervisor in everything, because the person who approves everything that you do is your supervisor. And you have to keep following up on the procurement people and follow up on your supervisor also. Any more questions?
Okay, can I go?
Do you have any? Oh, sorry.
No, fine.
No, you can take it. I was just going to ask if there were any questions for Sue.
Okay. So the power came back, so the signal will be fine for the rest of the meeting. I forgot to say that I'm a community service OT. I'm sorry. So I haven't been doing any procurement or anything like that. But I'm lucky that we have a really big team here. So we've got, including myself, 3 OTs, 3 physios, 2 speech therapists, and 3 audios. So we do see a lot of patients, but the days differ. Some day we'll have a lot of patients come, and then other days it'll be very empty. So we've got 6 wards here, 2 female, 2 male, and then 1 peds and 1 maternity ward that we see. So between 3 OTs, we each take 2 wards, and then we'll just rotate through them. And we just always make sure that there's 1 person in our OPD. So in OPD, we usually book around 8 to 10 patients a day, and then whoever's in OPD will see them. But we don't book more than that because there's always work. So if it's a really, really busy day, we see the patients who were booked first, and then we ask the walk-ins to wait. Yeah, and then in the wards, how many patients you see depends on how full the wards are at the time. So we've got a referral system set up, but it's not working that well. So we've asked doctors when they think there's a patient who needs rehab, we've got a folder in each ward. So then they just write us a note. It will say either OT, physio, speech, and then the name of the patient, and we go see. But they don't refer everyone who needs rehab. So we'll often do our ward screening. We'll have days where we do screening of the wards. So we'll just go around all of the patients, seeing who could benefit from rehab. I don't know what else to add besides, oh wait, we also have different groups each month. So we've got a huge amount of certain patients. So we see a lot of CP kids. So every 2 months we run 3 CP groups. Then the physios run CVA groups. We've recently started a skills development group for people with intellectual impairments. And we also do monthly outreaches. So because we've got so many patients, we try to do a lot of groups and a lot of outreaches so that we don't have to see everyone on an individual basis. But yeah, like I said, I don't do procurement or a lot of those things because I'm ComServe, but my supervisor, the head OT, I know she does a lot of that, but I can't tell you anything about it. I think that's all.
Can I ask, sorry for Megan and for Siwe. I wanted to ask, but my connection went a bit off, sorry. Dinawa mentioned that they do clinic visits twice a week. Is it the same for you as well? Or are you both solely based in the hospital?
Are you asking if I do clinics?
Clinic visits, yes, twice a week. I think Danoa mentioned that.
So we don't do clinic visits twice a week because we just mainly work in the hospital. So we'll see our patients normally and we'll run dupes. We only see clinics maybe once or twice a month. And it's mainly for health promotion. And when we do go, we meet with the nurses that's there, and then we do a session on what rehab is. So we'll have one OT, a physio, speech, and an audio go. And then we'll chat to the nurses about what we do and then who they could refer to us. Just because we do see a lot of patients every day, so we can't be in clinics all the time.
Okay, for us this side, we do want to see clinic patients, but we are struggling with transport. Our hospital currently has like one van, one truck, and one sedan. The sedan is usually occupied by the administration offices when they have to go to Bisho or the district. That's usually like 4 times a week. And then the van is always like occupied. And then the truck is only, they only use it inside the hospital. So we really struggle with outreach this side. And the way we can do outreach is if you have your own car and you want to do it. But it's been a struggle. But we still trying to get our own rehab vehicle, but it's gonna be just a tough task. But yeah, this side, it's a lot of advocating. You have to advocate for stuff.
Thank you for that.
Okay, so maybe we can move on to the next question. Okay, so the next question, oh yeah, I'm unmuted, is how is communication between you and your patients? I think mentioned something about communication problems when she was starting with her intro. So I want to know how your communication is like with your patient. Do you find that you have language barriers, and does that like hinder your adequate communication with your patients?
Yeah, in the beginning, it was pretty tough. I would start with the issue of dialect. I didn't know that Eastern Cape is divided into Transkei and Saskei. So they all speak Xhosa, but then it's different. It's different and it's vast. So the only Xhosa that I knew was the one that I hear on TV. And I thought when I came here, it would be easier for me to kind of like, adjust to it. So so where I was last year, they had interpreters, So there were like people in the community who like were a little bit illiterate, like who were a little bit more literate. So they would be hired, and then they would act like as your interpreter. But the issue with that is that they would be on our payroll, so they're not paid by the government. So the money would have to be deducted from your salary, and it was like 1,500 or something like that. So I was like, no, like I can't have that amount of money be deducted from my salary. So I refused to have an interpreter. So I had to learn basic terms that I would use in my consultations. So those terms, I derived them from what the local people use, and I had to kind of like grab those terms and actually come up with what I think the patient's problem is. and confirm with someone in the room and ask, is this what the patient is saying? And then if they say no, or if they say yes, they will just tell me what to say in order to like make the consultation easier. And also we had I think it's community health, it's community health workers. So those ones, they are in the local clinics that we used to see. But those ones, they are employed by NGOs. So another popular thing is that you will be working a lot with NGOs as in the rural area. So it's very important to kind of like familiarize yourself with the different NGOs. So there were NGOs who were community health workers. So what do they do? So because we cannot literally go into each and every village, what they would do is that they would go deeper into the residential areas, pick up patients that they feel that they need our assistance, and then they would bring them to us. And then we would do a joint session where it would be me, the community health worker, and the patient. And then also my language comprehension and my expressiveness of Xhosa language got better. And the only challenge that I had was understanding old people, especially the female ones. I don't know why. I think their Xhosa is a little bit, I don't know, sophisticated. I don't know. I had difficulties hearing that. So in those type of situations, if I do a consultation, I would also do a review. I would also give them a review date. And then I would also ask them to bring in someone who I can at least communicate with them on the other person's behalf. Like if I'm doing hearing aid fittings, it was the most difficult thing for me, because I would be torn between, do I give this patient a hearing aid because they need it? But then when I look at, will they be able to manipulate the hearing aid for it to be useful to them? It'll be difficult because they don't understand technology. It got to a point where most of the times my consultation rooms would be I'd be literally fixing people's phones, especially the old grannies. They'll be like, no, my phone is so soft. Can you please turn the volume of my phone? Can you please do this on my phone? It literally became that. So I feel like you become whatever the situation wants you to be. If you're an audiologist, you become an audiologist. If most of the time, people don't even know what is wrong with them. So you have to actually probe, to actually take it out of them and say, this is the problem. They would just say, I would say, what is the problem? They would say the ear. I'm like, okay, what's wrong with the ear? And then you say, and then you ask, okay, when did it start? When did this happen? When did that happen? So they are also their expressive language is also they're not as vocal as people in the cities are. They're more, I don't know, let's say, I don't want to say respectful or fearful of healthcare workers, but they just go with the flow and they trust your opinion. So that's how my communication has been, but it has vastly improved now. It has vastly improved. I understand Xhosa much better through that. So yeah, that's that for me.
Funny enough, that's not just in the hospitals. Even when we go home, Omakulu and the Tamkuls always have their phones being fixed and stuff. So I believe you. I believe you. We can have the next speaker answering.
Okay, so I have not had a problem with communication because home language is Xhosa. But yeah, the problem is, Xhosa has many dialects. And I'm come from the Hlubi dialect. And then here it's a lot of the Tembu dialect, which is pure Xhosa, some people say. So you do have terms that sometimes catch you off guard, but yeah, in terms of communication, it's been fine. But then what I've noticed is, like, for me, unlike the communication challenge I have is with the young people, which is 40 years and younger, because you get a lot of differences. There'll be some who come with, it's not a communication thing, it's an expression of things. Some, you hear the term amapara, some come with that, and then you have to also meet them there so that the session keeps going. And then some are very reserved, but everyone has different, so far, everyone I've met has a different personality, and you always have to adjust to that. And then one time I was with a Sotho speaking patient. Luckily, I know a little bit of Sotho. Yeah, I was perfect in it, but now, due to not using Sotho for some time, it's still a bit tricky. But I had a Sotho speaking, and it was not like a Sotho speaking like from Gauteng, because my Sotho is Gauteng Sotho. It was a Lesotho Sotho speaking person. Yeah, it was not nice, but I got around it. It was so much fun though. But yeah, communication, I've not had a lot of problems. It's just that communication with management where I have problems, but that is mainly politics and everything else. But it's been fine. It's been nice.
Do you find that you have the same issue with patients being more quiet or reserved, or are your patients very forthcoming and yeah?
For me, I have, like, from varsity, like, people know I've been an expressive person. So my challenge has always been with the reserved patients. Those who are very expressive, like extroverts like me, I have no problems. It's always with the reserved where I have to now go back into the tools where you learned in varsity, you've learned at home, of how to speak, like with the gogos, or sometimes when you have to speak, like with, sometimes you meet royalty here. Luckily for me, the patriarchy helps, you know. When you're like a guy, you do, like, when you're speaking to elders of the community, you come, my size, I'm a very big person also. So my size, my build, the fact that I'm a male, it does help with communication barriers where it's like, this is a man's space where you're like, and then sometimes you get very, like in Cape Town, you get a diagnosis like where someone has an erectile dysfunction. In Cape Town, they could be seen by anyone and they're fine. This side, you get to a point where you're like, there's only like 3 males who are in like the clinical team. Sometimes they would have to call me as a physiotherapist, and then now you have to be busy translating things from the doctor's point of view to the patient. But it's quite, that's why I'm saying I've not had any problems with communications. Yeah, maybe the females might, sorry, my female presenter might present something different, but so far, because I'm a man, sometimes it helps.
Mm-hmm.
Done.
So for me, I started out really rough here. But I don't think it's mainly because I'm a female. It's got a lot to do with race and the dynamics that come with that. Because I'm colored, but to everyone, I'm umlungu. So it already creates this barrier with your patient. But I've worked around it. So when I first got here, it's very weird because everyone treats you differently, not in a bad way. It's just not usual. So everyone's interested, everyone's friendly, they want to get to know you. But it was difficult with the limited course that UCT teaches you. So I don't know about the other degrees, but we've only got half a semester of CLOSA, and it was basic phrases, nothing that I actually used here. I don't think I've used anything from UCT besides the basic reading. So when I got here, I had to pick it up really quickly. I think what helped me a lot in the beginning was just having all my notes in front of me. So I literally had my translations printed in front of me because we didn't have an interpreter. But the patients, I feel like they felt a lot of sympathy for me because I'd start off by saying, listen, ndiyazama ukuthetha, I don't know. And then we just figured it out. And recently we got an interpreter, but I've learned to work without one. So, I mean, it's not great, but it works.
Thank you for that, Megan.